Yeah, good evening, everyone, and thank you for coming. Sorry for a little bit of a late start. We really happy to see such a great turnout, and in fact, a better turnout than we thought we were going to have. So wonderful to see you all here tonight. My name is Kathleen Helgeson, and I'm the coordinator of the Resource Center at the Center for Hope here at the McCharles site. And we are very pleased to offer this session with the generous funding support of the Cancer Care Manitoba Foundation. I'd also like to take this opportunity to acknowledge that we're meeting from all regions in Manitoba, the traditional land of the Anishinaabe, Cree, Ojai Cree, and Dene people, as well as the homeland of the Red River Métis. Our thoughts tonight are also with all the people in Manitoba that are impacted by the forest fires and wildfires that are going on. So I'd also like to thank the members of the CLL team who have helped plan this event, the 3 volunteers that have helped and offered their time tonight to help us out, and also to my coworker, Allie, who's hidden off camera here for all her technical support. This is the first time that we're actually hosting an event where we're in person as well as using Zoom. So it's been a little bit of a learning curve for us to get everything right. Hopefully we got it all right. So just some basic housekeeping details. The women's washroom is out these doors and to your left, and the men's washroom is out these doors and just down the hallway. So you were probably given a little notepad and a pen when you came in. That's because we'd like you to keep your questions until the Q&A period at the very end of the session. But we thought you might want to just jot your ideas or questions down when you think of them. And then at the end of the session tonight, when we have our Q&A, you can ask your questions to the presenters. For those of you joining from home, you'll notice that your microphone and your video are turned off. And if you have a question during the session, you can click on the Q&A and type your question. You can also choose to ask that question anonymously by checking the Send Anonymously box before you click on the blue arrow to send. So Allie will be recording your questions as they come in. And then again, at the end of the session, we'll share them with the presenters. Lastly, we'd like to provide you with an evaluation both here and through Zoom. So your feedback is really important to us. It helps us plan future sessions. So we invite you to complete that evaluation as well at the end of the session tonight. All right, it's my pleasure to introduce our first speaker, Dr. Lynn Yang. Dr. Yang is a hematologist and researcher at Cancer Care Manitoba and has a clinical practice in lymphoma, including chronic lymphocytic leukemia and general hematology. She attended medical school at McMaster University before returning to the University of Manitoba to complete her internal medicine and hematology training. Prior to medical school, she completed her PhD at the University of Toronto. The focus of her doctoral research was on cancer-driving genes in acute leukemia. Her current major area of focus is in CLL. Welcome.
That's perfect for me. Yeah, that's perfect for me. Online is good? Okay, great. So thank you, Kathleen, and everyone for putting tonight together. And most importantly, thank you for coming. This great turnout is a testament to what we're doing in the clinic, and just wonderful to see this group of people coming together. And it's nice to see some familiar faces, but also some newer faces. And that's what tonight's about. It's about getting a group of people with one common issue together and networking and get to know the disease, the people involved in your care, and networking with others who may be in the same place as you. So I have been tasked with the talk of introducing the concept of CLL to just kind of put everybody on the same level. By no means is this all by me. I want to acknowledge a few people. There are 2 CLists that I want to acknowledge. One is Dr. Johnson. I'm frantically looking at there he is. Okay, who has been a pioneer and a legend in CLL and really laid the foundation for what we do. So I have a lot to be grateful for. And he mentored me in CLLs over 10 years ago. So hopefully I carry on the legacy as he has left it. As many of you know, it may not be in the forefront of clinical practice recently, but he is absolutely still engaged in our CLL care, just more so in the background. And I also want to acknowledge Dr. Banerji, who you'll hear later from today. She is my better half. We are, the two of us are looking after the CLL patients in the program here. And she also mentored me and trained me. So I have a lot to be grateful for. There's too many people to lump together in the team from both past and present. But there's so many people that have been involved and are involved that you can't just put them pictures together, but nurses and clerks and researchers and only some of them we'll talk about tonight, but there's so many folks that just came together and made this all possible. Okay. So CLL is, oh, I need a quick favor just before I start. It's cutting off my slide, you know what I'm talking about? Maybe if we put it in this corner. Yeah. Or hide it. Right? You can see it, right? Like, because you're, yeah, exactly. Yeah.
The people that are connected by Zoom, they would see it behind it.
Oh. Oh. Okay. Yeah. Yeah, that's perfect. Yeah, just because it's hiding a little bit the slides. Okay, perfect. Okay. So CLL, as you heard from us, is chronic lymphocytic leukemia. I'm going to break it down a little bit because it really speaks to what this condition is about. So leukemia simply means we can detect cancer cells in the blood. A lot of people I know hear the word leukemia and there's just the strong emotion that's associated with it, but all it really means is cancer in the blood cells. You feel a strong association with it because people think it's an acute leukemia, but CLL is a chronic leukemia. So that's what the C stands for. That means it's slow growing. It doesn't kind of have that flavor of acute and fast and aggressive. CLL, it is the most common adult leukemia in North America. So we see a lot of it, we have a lot of it, and we have also the advantage of being able to study it because there's so many people affected by it. Lymphocytic is representing the type of blood cell that's given rise to the cancer. So these are lymphocytes. And lymphocytes is a type of white blood cells. So really commonly what happens is someone goes to their doctor to get a blood count done. Almost everybody gets a blood count done now if they're going to see their regular doctor or go to emergency room or any kind of healthcare facility. And when they do a blood count done, what they're getting done is what's called a CBC, which is a complete blood cell count. And that includes white cells, red cells, and platelets. Those are the really three main blood cell types that we're looking for in the CBC. And when you get that, it will show that the white count is increased or more than it out of range. And lymphocytes would be identified as the type of white cells that's giving the white cell count increase. So that's really how things get started for CLL, is that you routinely have this blood work, finds that the lymphocytes are increased, and that's how we pick it up. But that's where the name came from. Lymphocytic is from lymphocytes because that's the cancer cells. And as I alluded to before, chronic is indicative that this is a slow kind of growing type of leukemia rather than the acute ones that we often think about. The average age, kind of North America-wise, is about 68 at the time of presentation, a diagnosis when they come to the clinic. Our Manitoba population, and thank you for all those who participate in our research program, we have this information. Our Manitoba population is about 72. So a little bit older than kind of the general world demographic. And is a little bit more prevalent in males than in females. Just about 2 to 1, like twice as many males than there are females. So, oh, I went backwards. So generally what would happen behind the scenes, just to give you a perspective of how you get to the clinic, is you get a blood count done wherever in the province of Manitoba. The doctor who did the blood count looks at it and says, oh, the lymphocytes are increased. That automatically triggers a letter to cancer care, which we call a referral. So this letter would say, I saw so-and-so in my clinic, and I did a blood count, and the lymphocytes are increased. Can you help? It doesn't have to come with the diagnosis. It just comes with what is the problem. And when we receive that letter, a doctor looks at it. Could be Dr. Banerji, could be myself, could be other doctors within our department. And we will do a confirmatory test. Sometimes that confirmation test has to be, we ask the family doctor to do it if they saw you. And sometimes we do it. So it doesn't matter. Anybody in the province can do it. And when we do the confirmation test and the results come back as CLL, then you get assigned to see us in the clinic. You either see Dr. Banerji or myself. So that's what's happening behind the scenes. Let's talk a little bit about CLL and where it came from. So this is going to be a little tricky. All CLL came from a precancerous state called MBL. MBL is monoclonal B-cell lymphocytosis on the left side. That is a condition where we see CLL cells in the blood, but it's such a minimal number and low burden that it doesn't qualify as leukemia. So we don't consider that a cancerous condition. We say it is a non-cancerous condition, but it needs monitoring. And why does it need monitoring? Is because some MBLs will stay MBL forever, but then there's some MBLs in which that CLL, little bit of CLL that's in there, will start expanding. And when it grows like a cancer cell, at one point, it's going to tip over. And we say, okay, there's enough in the blood now that we're going to call it leukemia. So that's kind of how I've tried to depict it here, is start with MBL, and then that population can grow, and then you turn into CLL at one point, and the numbers are fairly telling when that happens. That's the bulk of what we see. There's a smaller group of folks where the MBL is there, but instead of expanding in the blood and make it into CLL, these cancer cells are expand not in the blood, but in the glands and sometimes in the spleen. So it kind of skips that blood part. And we give it a different name. We call it small lymphocytic lymphoma. Lymphoma is cancer of the lymph nodes. And it's really just a medical term for doctors to talk to each other. But when you sample these nodes, these folks with SLL, and you like take one of the glands out and you look under the microscope, it's CLL in there. So instead of being expanded in the blood, it's expanding in these glands. So for all intents purposes, CLL and SLL really behaves the same. Same prognosis, same treatment, same kind of disease history. So in the clinic, for my talk and for ease of communication, we just say CLL clinic, but it's really, we see MBL, we see CLL, and we see SLL in our clinic. We see everybody. But I just say CLL, just to make it easier. So you may hear us talk about this when we meet you for the first time, and we say, oh, you actually have SLL, and that's why. But they're treated exactly the same. So once you get diagnosed with CLL, it is expected over time that your cancer cells will grow. And this is one example of somebody's blood count, and I just graphed their lymphocyte count. So you can see they started off, oh, I'm sorry, it's so small. I didn't realize it'd be so small. In 2016 on the left, very low. You don't have to know the numbers, but you can see over time, it starts picking up and it's picking up. And that's a typical pattern. We do expect that. And when we see kind of slow growing pattern and when we see folks in the clinic for the first time, many of the patients do not have any problems with their CLL. It's not really affecting them, is what we say. It's not really affecting their daily lives. It was just kind of like a bit of a incidental pickup when they had a blood test. And that's a lot of our patients. CLL kind of develops very slowly over time. It's not burdensome. It's not causing problems. Some patients at the time of diagnosis, or they've had CLL for a really long time and that kind of CLL growing and growing and expanding over time, we can start seeing more of it outside of the blood. So we can see the glands getting enlarged. So we call those nodes, lymph nodes. And we can see the spleen getting enlarged. So I've shown you a couple of pictures here. I hope they come through. It's kind of hard when you're not seeing the whole body. But on the left is a gland just underneath the jawbone here. That's one example of a gland that we can feel. And on the right here is a cartoon of the spleen. So it's on the left side of the abdomen. It's usually tucked underneath the ribs. But if it gets a little bit large or larger, it starts to push down and we can start feeling it when we do the exam. And then lastly, the CLL cells could expand and start taking up room in what's called the bone marrow, which is the factory that makes all of these cells. So when the CLL starts expanding and taking up that room, your red cells and your platelets may drop as a result of that. So this is how we would stage your disease. I didn't list it here because it's not really that important, but this is how we stage it. Do you have stage 0, 1, 2, 3, 4 disease, depending on if you're progressing through these. And this is the natural history of CLL. People, this is how it gradually builds over time. It starts with the blood and the glands, and then the spleen, and then eventually the other blood counts. It doesn't mean you need treatment just because you're going from one stage to the next. There's specific criteria that we look for to say, okay, when is it time? And we'll talk about that. But I wanted to emphasize, just because you have some glands or you have an enlarged spleen and you're otherwise feeling well and your blood counts are fine, doesn't automatically mean you need treatment, okay? This is all more or less a communication tool for us to kind of gauge where things are at. Even though you're not getting treated for your CLL and it's just being monitored, you are, early stage, later stage, doesn't matter. We know the sheer presence of the CLL cells in the blood, or SLL, you get my drift, does weaken the immune system. Lots of good studies went in to prove this and to show this. So how does that impact you? One is you may start seeing more infections, and they could last longer or could be more severe than they used to be. You could have risk of other cancers come through. So we call the second cancer. So big ones are like lung, colon, prostate, breast, skin. And really want to emphasize skin in there. So we have some general guides as to what we recommend for these, which I will point out in a little bit. Want to show you I really want to emphasize the skin cancer component, because Dr. Johnston's work showed that folks with CLL have 5 times more likely to develop skin cancer than any other folks with cancer. So that's important. So always have your skin checked. And these are just examples of some skin cancers. If you catch it early, you can treat it, right? So if you don't need treatment in the CLL clinic, it doesn't mean we're not going to follow you. In fact, we're going to continue to follow you. And we call this active surveillance or active monitoring. And this is applicable to a lot of our folks, especially when we first meet them, right? Because most of them will have really low burden disease and doesn't seem to impact them, but we need to keep an eye on the counts. And the philosophy, and what we know from a lot of studies is that there's a lot of benefit and it's very safe to do this. We have looked at studies to say, well, what if we treated everybody at the time of diagnosis rather than waiting until they really need treatment? Studies have not shown that you'll live any better or longer by doing that strategy. So it's absolutely safe to wait until we see that there's signs that we need to treat. And if you didn't need treatment, you didn't need exposure to those medications and their side effects. So you could potentially be spared of that for some time. So there's a lot of good rationale for observing. I want to talk about a new monitoring clinic that we're doing. Some of you already know this, but for those who are not, I want to spend some time about it. This is in operation for the last year and a half, almost 2 years now. And it is a clinic that does monitoring of low-risk individuals. So it's led by Brittany, who is the nurse on the left, picture taken during COVID. And beside her is Lindsay and another nurse. And what they do, and they're very well-trained CLL nurses. They know CLL inside and out. And what they do is in working with your family doctor, so we're engaging family doctors in checking your blood count and checking in on you. So we ask family doctors to do blood work, at least once a year, which most people should anyway. And from our end, we will also arrange blood work, and Brittany will call you after that blood work is done to see how you're doing. Her assessments are reviewed by Dr. Banerji and myself. So we're always engaged in your care, but not perhaps right at the front. If everything looks well and everything's going well, we just repeat this for the next year. At any point when we think some activity is changing or there needs to be a reassessment, Dr. Banerji and I will get involved with that. And there's a really big advantage. See, we know CLL, we're the provincial experts. Brittany knows CLL, we're there as your support. And we're not only looking for CLL, to be honest, we're looking at the blood counts clearly, but we understand CLL. We know to ask for those questions about infection. We know to ask those questions about the second cancers and the skin cancers. These things may be out of the scope for some primary care providers. So we're there to provide our expert assessment. So many of you may be informed of this new monitoring clinic. So in the meantime, if you're on observation, what can you do? There's a lot of things you can do, but a lot of this is intuitive, stay healthy, exercise, eat well, treat infections when you get them rather than waiting for it to build up because it could get more severe. Some CLL specific recommendations, sun protection because of skin cancer risk, vaccinate to help yourself boost infections. I'll talk way more about that in my second talk today, and follow the Manitoba guidelines for cancer screening. We also like to recommend vitamin D, 2,000, two of the white little ones, or you can buy them at 2,500 international day pills as well. It helps boost a bit of the immunity. So when would we say, okay, maybe now it's time to talk about treatment? I get this asked a lot. What number are you targeting? There isn't a number, to be honest. There is no lymphocyte or CLL number cutoff when we say above this, you need treatment, below this, you're fine. It doesn't work like that. What we're really looking for is the pace of how everything's changing and how it's affecting you. That's so important. So we're looking at how quickly the cancer cells are going up, but we're also looking at if you have these glands, if you have these enlarged spleens, are they growing to the point where they're causing you discomfort. You have difficult time lying on that side or with your neck, it's impacting you. You are just so tired and hard to get through your day. You're losing tons of weight that you can't explain, and it's starting to impact you. Your blood counts are starting to drop because of that crowding of the CLL in the bone marrow. So your red cells and your platelets are starting to drop to a certain level. We think then it's time to turn things around. And infrequently, but not so infrequently, we have folks where the immune system, when I talk about CLL and the immune system, the CLL triggers a miswiring of the immune signal, and the body starts attacking its own blood cells and its own platelets. So that's a bit of an acute process, and we have to get involved right away, and then you will need treatment for your CLL at that point. So when it's time to start having that discussion about CLL treatment, we will be talking about testing your cancer cells for genetic markers. So there's different ways you can language this. It can be molecular profile, looking for genetic markers. What we're really doing is taking the sample of your blood where cancer cells are floating, extracting out only the cancer cells and testing for genes within your cancer cells to see what they look like. It is really done for two purposes. One, it helps us gauge if you have any higher risk mutations within your cancer cells. These are not mutations you inherited. These are not mutations you're given to your children. These are inherently in your cancer cells. So we're looking for those, are you high risk, medium risk, low risk mutations? And with that information, it helps us counsel you on the treatment that we have to offer and what it means. So we integrate the clinical picture, how you're doing, you as a person, and these molecular results. And Dr. Banerji talk more about how we integrate it. But just briefly, what are we actually looking for? We're looking for two different processes. The first is called a p53 gene. And it's so important that we look for it in 2 of the 3 tests. So we're looking for it at 2 different ways to really make sure we don't miss it. But what is p53 and why is it so important? So you kind of think of p53 as like a warrior, a guardian of our cells. It keeps bad cells out. It keeps cancers out. It's just that really big, strong, ultimate warrior. So when you don't have p53 because it's mutated, so we're looking for problems with the p53 that renders the p53 not functional, that's when cells get an advantage to grow, and that's how cancer cells starts proliferating and growing and could have an advantage because they don't have that p53 to block things out. So if you do have a p53 mutation, we consider this a higher risk mutation. The next set of genes that we look for is a mouthful. For short is IGHV. It stands for immunoglobulin heavy chain rearrangement. All it means is we know this gene is important for CLL development, and we wanted to see how it's doing. We want to see that it's mutated. So here, mutated is good because it means your lymphocytes have developed properly. Remember, CLL is a lymphocyte problem. So if you have something that's unmutated, that tends to say to us, it's a little bit higher risk. So we put you in the intermediate group. And if you don't have problems with either of these, we call this lower risk. And it helps us counsel you on treatment. So with that, I think I still went over time. With that, I'm going to ask Kathleen to come back and invite the next speaker.
Thank you very much, Dr. Yang. So I'd like to now introduce Dr. Versha Banerji. Dr. Banerji obtained her MD in residency training in internal medicine and hematology at the University of Manitoba. She completed a postdoctoral fellowship in translational research at the Harvard Cancer Center, Dana-Farber Cancer Institute, and Broad Institute of MIT. She is a clinician scientist at our Cancer Care Research Institute and an associate professor at the University of Manitoba. She is the inaugural director of the CLL unit at the U of M in Cancer Care and leads clinical trials and population-based treatments studies locally. She manages the research team in clinical, fundamental, and translational research and is the principal investigator for local, national, and international clinical trials at Cancer Care. Welcome. Thank you.
Good. All right. Thank you very much. Thank you for that very kind introduction. And welcome to everyone here. I know that everybody's in a different part of their journey. So obviously some of what Lynn talked about earlier is relevant to your story. And some of you may have already experienced treatment or are in a different part of your journey. So this information is quite generic and it's really for everybody as a whole. And there might be specific things that you identify with because you've had those parts of your journey. So hopefully we can help inform what we're able to do now and potentially what is coming down the pipeline. So these are my disclosures. So I also would like to acknowledge Dr. Johnson for creating this beautiful figure, which I really love. And it really helps us to paint a very visual picture of the patient journey. And so I think it's important to understand. So on the left, you have the tumor load. So patients with a diagnosis of CLL or SLL. And on the bottom, you have the number of years. And this is kind of a visual graphic of kind of the journey that a patient who undergoes treatment may go through. So there's that initial phase where there's active observation, and then they get to a certain point in their disease burden or they have symptoms where they require treatment. So TX means treatment. So then that period is your time to first treatment. And then people go into a remission. And then eventually, because we know that this is a condition that people live with and aren't cured from, they will go into a remission. And then eventually, depending on the treatment and how long it lasts, people will eventually relapse. There are some people who will only require one treatment in their lifetime, and there are many more that will never require treatment. So important for you to understand. So when you're reading the literature, or if you're really into clinical trials or papers on CLL, these are common terms that are often used: time to first treatment, time to next treatment, progression-free survival. So that's the time that your cancer is controlled by your treatment, and your overall survival. And a lot of that depends on how you respond to the treatment, but also other things that we talked about, the infections and the second cancers. So what are the goals of treatment when it comes to a patient with chronic lymphocytic leukemia? So we're really looking for effective and long-term control of the cancer, but we're also trying to improve the patient's quality of life and manage their symptoms. But we can only do that if we can find treatments or use treatments that are tolerable for our patient population. And then what are some of the secondary goals? We definitely want our patients to better. We want them to have better outcomes. But some of the things that Lynn talked about were, your tumor cells can develop mutations. So hopefully by treating your cancer, we reduce the ability of your tumor cells to gain more mutations. The other thing she talked about was the development of infections or second cancers. So maybe with our treatments, we can reset the immune system so that patients aren't more prone to infections or these second cancers. So these are sort of the secondary goals and benefits of the treatment. So what are the indications to treat? So we talked about a rapid rise in those lymphocytes, but we're also looking for the impact that has on the other blood cells, either a drop in the hemoglobin or the platelets. And those numbers are guidelines. Obviously, patients and their symptoms will drive the number one reason to treat. So if you have those uncomfortable large lymph nodes or spleen, or you have severe symptoms like tiredness, sweats, or weight loss, and then the immune problems that were alluded to earlier. And as mentioned before, we have patients in this room who are walking around with various different levels of white blood cells. Some of your white blood cells might be 4, some of them might be 400, but that's not in itself an indication to treat. It's really a composition of any of these criteria up here, but number one driver for treatment is often symptoms. So the question that I have been asked by other patient groups when I've spoken at kind of national conferences is, how do we assess the symptom burden? And I think that's a really important question, because each of you is an individual and you have your own story. And so your presentation will be unique. But what are the key things that we want to understand? So the sweats can be multifactorial. They can be related to hormone problems. It could be related to thyroid problems. And so we need to understand how they're affecting your quality of life. When it comes to fatigue and decreased energy, this can also be multifactorial, and it really depends on what your baseline is and how it's changing. How busy are you? Have you noticed that you've slowed down? Do you have a good night's sleep? Do you have other medical issues, thyroid problems, sleep apnea, depression? All these things can influence your mood. And these are really important for us to understand, because our goal is to improve your quality of life. But if you have other medical problems, we may not be able to improve your quality of life. Can people not hear me? Okay, I can. Hello. All right. Okay. So let's see if I can do 2 hands. All right. So the reason we ask about these at every visit when you come to see us is that we want to make sure that we get it right. We have treatments that have improved a lot, but they still have side effects and risks. And we want to ensure that the shared decision results in an improved quality of life. And we want to ensure that our interventions improve your symptoms. So what are we actually trying to target? So when it comes to the biology of CLL cells, we know that these cells are in a position where they're not dying their normal kind life cycle. There's a problem with their ability to die in a timely manner, and they continue to grow. So cell survival and cell growth are basically tipping the scale so that these cells accumulate within the blood, the lymph nodes, and bone marrow. And they're supported by the other tissues where these cells live. So these cells are found in your bloodstream, in your lymph nodes, and in your spleen. And it's those cells that support those environments that help those cells grow and survive. So our treatments are basically used to try and target and sever those relationships so that the cells die off, to make room for the normal cells to do their job. So in the past, we used to base our treatment strategy on how old somebody was, what their medical problems were, and how well their organs worked. And that's how we selected which treatment, specifically chemotherapies, would be used for patients. And I think this is one of the biggest things that we've had to discuss with our patients when it comes to treatment, because often they come in walking in the door saying, I don't want chemotherapy. I'm too old for chemotherapy. But the reality of the situation is I haven't prescribed chemotherapy in like 5 years. So we've moved away from what people think is a scary treatment to more targeted treatments. And people will ask the question, well, what is chemotherapy and what does that mean? So we use non-specific drugs to basically break down the DNA or prevent the DNA from being repaired for cancer cells. But the problem with that is that we were also attacking healthy cells, which is why people would end up with hair loss, why they would end up with diarrhea or vomiting, because we were also targeting the gut tract as well, because those are all cells that rapidly turn over naturally. So by moving away from these drugs, we hopefully have prevented a lot of those side effects. So these are the different drugs that were previously used to basically prevent the cell from going through this cycle and going from one cell into two. And it's not really relevant. The only reason I show this slide is that we've come a long way because these were the treatments of the early 2000s to 2010s, I would say, up until about 2015. So we used to give single agents to people who were frail, and that meant their remission was only about 12 months. And if you were fit, our youngest patients less than 65 years of age, and you had no medical problems, you would get our best treatments where the remission was about 5 to 6 years. But it came at a significant cost. So the better the treatment, the worse the side effects. And 75% of patients would have some of the most serious side effects, which would mean an admission to hospital, need for antibiotics, and care within the hospital system. And these were studied in patients with this condition who were also older adults. But this was the best we had at the time with the knowledge and the science information. So today's targets really target that cell growth pathway or reactivate the cell death pathway. So one of those targeted treatments that some of you may have received or are familiar with is an antibody. So an antibody is basically a protein that binds to a marker. So here is what a CLL cell looks like. This is the uniform the CLL cell wears. And the CD20 is one of the key markers of B cells. So these antibodies can come and basically bind to that marker and the cell dies on contact. So this is one of the targeted ways we can get rid of the CLL cell. This medication is often not used on its own. It's often delivered in combination. All right. So this is the inside of the communication network of proteins within one of your CLL cells. So basically, there's a signal that can come to the surface. It creates this chain reaction that ultimately allows the CLL cell to survive. And smart scientists basically have discovered the components of each of these pathways. And even smarter scientists have found drugs to actually target specific proteins. And the drugs that we currently have in our clinic today that target the BCR or the B cell receptor signaling pathway are ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. And they do this by basically inhibiting the activity of that BTK protein and are known as BTK inhibitors. They are extremely important drugs in the history of CLL, and they have changed the outcomes for patients in our clinic. And they're oral medications that can be administered in the comfort of your own home and monitored. The other drug activates a cell death pathway. And so the reason this is important is because there's a balance between cell survival and cell death. And the CLL cells have forgotten how to die. So this medication basically allows the cells to reactivate that cell death signal so they are eliminated from the system. Also an oral medication, but a little bit more complicated to deliver. So the reason we are so excited about these drugs is because we can give them easy, but they don't come without side effects. So the earlier generations of the medications can have issues with your heart, your skin, and your nail, and still can cause infections. And I always tell patients that this isn't going to happen to you specifically, but it is like the infomercials on TV where they list every single side effect that a person can get from a drug. What we have to share with you so that you and I and you and Lynn can make the decisions to pick the right medication for you. The other side effect of the venetoclax or BCL2 directed treatment is that we are constantly monitoring the blood for breakdown of the tumor cells. So there's a lot of blood tests that are done. There's a lot of monitoring that gets done. And it can still cause low blood counts. And there's always the risk of infections when we're treating a blood cancer. So currently, if you have a high risk CLL and you need treatment, the approved drugs are the ones listed on top for high risk, which are continuous treatments delivered on a daily basis until they stop working. If you have intermediate or low risk, in the old era, we used to give you chemotherapy, but in the new era, we have the ability to combine those cell death activating drugs with antibodies. And now we're entering the phase of potentially giving oral combinations for a time-limited treatment. And this is very exciting because it actually means we might be able to give even our highest risk patients time-limited treatment. So this is just an example of some of the information that we've gained from our clinic in terms of how different drugs have improved outcomes. So the blue line represented patients over a 10-year period that only received chemotherapy. And the further up the line is, the longer people survived. So the green line allowed people who had seen chemotherapy but had been exposed to some of those newer drugs overcome the failure of chemotherapy and actually survive longer. So I think it's really important to know. And now, I mean, we don't have the data now. We have people who've never seen chemotherapy that are currently in our practice. So we'll have different data on how well those patients have done. I think it's really important to understand how blessed we are in the province of Manitoba when it comes to receiving treatments for our patients with CLL. So the province of Manitoba, as long as you filed your income taxes, covers the cost of medications through the home cancer drug program. And so this is some data generated that based on how many treatments you received and the sequence of those treatments, the cost per patient in a lifetime. So if you had no P53, and that means you're not high risk and you got time-limited treatment, if you got either chemotherapy or the 12-month treatments, your costs were somewhere between $200,000 and $400,000 per person. But if you started with some of those continuous treatments, the cost went up to $800,000 per person. If you have a P53 abnormality, you are on those continuous treatments, and that costs for most of the patients remains elevated. But if you do start with a time-limited treatment, and now we'll have the oral time-limited treatments, those costs can come down by at least $200,000 to $300,000. And I know it's not about money, but as a citizen of Manitoba and a physician that's also trying to keep the healthcare system sustainable, it is something I think it's important, and I do discuss that with our patients as we're discussing what priorities are important for them, but also kind of how this reigns in terms of costs with the cancer treatments. So everyone wonders why I'm late in my clinic. It's because I have to explain the treatment algorithms to the patients, and that takes time because there's so many options. It's not one size fits all. And the reality is it's always a surprise or a change in their status. So I might not be expecting to treat someone, and then we have to have this detailed conversation on what is your molecular profile? What are things that align with your quality of life? Time-limited treatment, continuous treatments, accessibility. Can you come to the appointments? Do you have someone to support you? Do you have someone to drive you? These are all the things I'm constantly thinking about. So this is an algorithm of treatments that are approved in the first line setting. If you relapse, what's approved in the second line setting. There's more drugs being added every day. And this is if you have higher risk disease, what are the approved treatments, and then what's available. And the only reason I put this up is because when I'm looking at the patient for the first time, I'm not just thinking about what they're getting now. I'm thinking about what they have available to them, a treatment from now, or 2 treatments from now, or if you're in your current journey, what am I going to plan next? And so it is a very a lot of thinking goes into how we present the information, and a lot of consideration for your needs and your values goes into the treatment algorithm. So with that, I think that's my last slide. And then I think I'll turn it over to Kathleen.
Thank you, Versha. I'm going to invite Dr. Yang to come back up.
I'll be quicker this time. I know a lot of information has been passed on and takes time to digest, so I'm going to be brief. This one won't take too long, and I'm going to be very focused. It is going to add to the information overwhelmingness. I apologize. Yeah. So we pay a lot of attention to the immune issues related to CLL because, like I said, CLL, just the presence of the CLL cells can disturb that, whether you're on treatment or not. So you hear us ask a lot of these questions in the clinic and want to provide a rationale to why. So I've alluded to this already. We talked about, just 1 second, it's not in presenter mode because I have animations is not showing up. He gave away all the answers. They're supposed to pop up one at a time. And I like spend time to figure out how to make it all pretty. Okay, there we go. And then if we can, minimize that. You can just, that's it. Yeah, that's it. Okay. Okay. So we talked about infections. We talked about, oh, my animation is not working. Am I pushing the right button? Why is that, Kathleen? No, nothing is coming. Did I just go for it? No, I think I missed this one, right? Is this 4? Yeah. You might just want to do it. Yeah. Hello. Yeah, it works better here. Okay, I'm gonna just shift over here so be on the other side of the podium. Okay, so we talked about infections, we talked about other cancers, and we did also talk about this sudden kind of immune rewiring that breaks down your blood cells. And these are the key things when we talk about immune problems in CLL. What I really want to focus on is the infections today. We know this is common, and we know that it can be really burdensome and quite serious to an individual. It could lead to a lot of emergency visits. It could lead to hospitalizations. So we pay a lot of attention to this. Most of the infections are likely bacterial, bacteria causes pneumonia, chest infections, sinus infections, stuff. But honestly, anything is a go in CLL. We know a few reasons why this may happen. Some of it we can test for and some of it we can't. One is just getting older, unfortunately. One is that you've had prior treatment, particularly the chemotherapy that Dr. Banerji has talked about, because they're so disruptive to the immunity. And the other thing that we see is just this natural decline in your normal antibody production. So that's what I want to talk about today. So how do we kind of generally help you protect against infections? Look out for those infections, vaccinate. We do recommend that. It will boost your immunity. Just most recently, the CLL team has put together a 1-page recommendations for vaccinations for individuals with CLL. It is vetted against an infectious disease specialist also came on board and helped us put this together. So it's a very nice short summary sheet. You have all access to it. So if you wanted it, you can either contact your clinic, call the nurse, or Brittany has it. And we are also giving them out for our new patients that we're seeing because it's complicated, right? There's a lot of different vaccines, different schedules. So it's all summary, up to date, done, available to you. And we also can talk about replacing antibodies if you have naturally lost that production because of the CLL. And that's what I want to focus on today. So what do I mean when I say natural antibodies and you're losing and you're replacing? Okay, so, I will try. I'm not good on a PC. I don't know how about this? Okay, perfect, thank you. So we have what's called immunoglobulins. These are naturally made antibodies. We're born with them. We have them. They're there to help us with fighting infections, all sorts of infections. There's a few of them that we make. They all have alphabet names, but the most common one, the one that's the most abundance is IgG. That's immunoglobulin G class. And IgG can be measured in the blood, and IgG is what we can help fix. And with CLL, a lot of work by Dr. Johnson showed that IgG can change with the disease. So I've given an example of somebody who did exactly that. This is somebody with CLL who was diagnosed in 2004, and I've shown their IgG levels in blue there. You can follow the line on the left. From the time of the diagnosis of 2004 until 2013, no treatment for CLL. But over that time, you can appreciate that the IgG levels are falling. So that's the CLL effect. CLL is building, is starting to knock down your IgG levels. And when the levels are going really low, it puts you at risk for infection. So this individual got admitted to hospital for pneumonia, so bacteria causing a chest infection. At that time, okay, it is now time. We're going to replace your IgG. We're going to help your body boost them up, and we're going to start treating your CLL because that's what's causing the IgGs to drop. And then numbers go up, but over time, things may start dwindling again. This is all happening behind the scenes. When you come for blood work and we're taking all those vials, one of those vials is checking IgG. We may not be telling you about it every time, but we're checking. So when the levels get to a certain amount, a certain level, you are going to be at risk for infections. So we gauge how well your IgG is still working by how many infections you're having. So if you're having 2 or more bad enough infections that you need antibiotics, or you have one major admission to hospital for a bad infection, and you have these low IgG levels, we think you will qualify. It doesn't mean you need treatment for your CLL. It usually means your CLL burden is building up, but again, you still have to meet the criteria for treatment in CLL. This is independent of that. And the goal of replacing these IgG proteins is to not get rid of these infections, because this is only one of many reasons why you're getting infections, but to help reduce that burden so you're not constantly on antibiotics or more serious admissions to hospital. So how we boost it is by giving you donated immunoglobulins either through the veins or through the skin, mostly through the tummy. And these are blood products are donated, so it comes from Canadian Blood Services, and we would calculate a certain dose, and then we would give it. But there's huge differences between giving it in the IV versus giving it in the skin. So IV is called IVIG, and it has to be done at a cancer center. So there's another trip in. And oh, I have written once a week, but it's actually once a month. My apologies there. That's wrong. It's once a month. But the reason we require you to get it done at a cancer center is there's more side effects. There's a chance of a reaction, so we have to keep you monitored. And when you get the IV treatment, there's a huge boost in your IgG levels, and then it kind of drops quite suddenly. So you get a huge wave and then drop. On the other hand, when you get it in the skin, which is called subcutaneous, it is a home treatment because the risk of a reaction is very, very low. This is once a week, or there's a new once a month option. Depending on how much you're getting in, it could be anywhere between 15 and 30 minutes. And because you're kind of giving a low dose every week, you keep your IgG levels much more steady. If it is a small volume, you can just use a simple syringe and needle set, and then you can just infuse it yourself. But if it's a bigger volume, we have now pumps that you can load up, very easy to use. You don't have to be all techie to learn these pumps, and they will infuse it for you. We now partner with a company called OnePath. They are a patient support program, and they will actually get a nurse out to your home, and they will train you how to do these, either through the syringe or the pump, but they prefer the pump because then it takes it out of the patients. I said we could do once a week, and that's our traditional, and we've been doing once a week for many, many years, and it works great. Love it. But now they have come up with a once a month, just for those who are big travelers or for more convenience, perhaps. And you just end up giving yourself a bigger volume that once a month to last the 4 weeks. So there is a tiny bit more risk of a reaction at the skin because the volume is bigger, and it requires 2 needles because you need a stabilizer for that protein, the IgG protein, to last that long. So Dr. Johnson and a nurse, Erin Strew, I don't know if anyone been around when Erin was here, did a initial pilot study. So pilot studies when we're trying something. And because at one point, everybody was getting the intravenous. Everybody had to be booked in the treatment room, come in, managed. And Dr. Johnson said, why don't we try subcutaneous? There's some really good studies out there that it works. And he took over 100 CLL patients and converted them from IVIG to the subcutaneous version. And the results were overwhelmingly positive. Patients really liked it. They had control over their schedule. They didn't have to come to the cancer center. It kept people out of hospitals. There was 75% reduction in antibiotic usage. And it saved a lot of nursing and time in the treatment room, so we can dedicate that to folks who need chemotherapy that absolutely has to be given here. So that was an overall benefit of this program. So the take-home message is we do take infections quite seriously. Every time we see you, we're asking you, and you may not know it, but we're checking your antibiotic prescriptions. We can log into all of this electronically. We're checking all of that before we even see you. We know all of this. And then we're asking you about your antibiotics. It's because we know that this can happen with CLL. And if you do have low natural antibodies, we have a way to help you to try to boost that. And if you do need, if we think you do need some benefit, we'll obviously talk to you about it, but we are preferring the subcutaneous route if we could logistically deliver that and it's feasible for you. So I want to thank all the patients and their caregivers in helping us set up this program. We're the first in the province, and we're rolling this out to all other kinds of cancers because of the work that you helped us establish.
Hey, welcome back, everybody. I hope you enjoyed your sandwiches. I'm sorry we ran out of coffee, so a note for next time, we will definitely order more coffee. I didn't think that elderly people drank a lot of coffee in the evening, so according to my parents, they never do. So I was like, we don't need that much coffee. But we know for next time we will order more. Okay, I'd like to introduce our next guest, Cheryl Dizon Renante. Cheryl is the clinical lead of psychosocial oncology at Cancer Care. She has been a Canadian certified counselor since 2011 and has served patients and families affected by cancer for over 9 years, with a primary focus on serving those affected by breast cancer. Cheryl provides individual, couple, and group therapy for patients and family members. She also enjoys program planning and working with her dedicated colleagues at CCMB. Connecting with and supporting people affected by cancer is a very rich and meaningful work for Cheryl. Welcome, Cheryl.
Hi, I don't think people can hear me. How's that, folks? Much better? Okay. All right, I tend to wander, so I think that's why they're also giving me the microphone. So I also want to hide from the bright light. So I hope that this is okay. My slides are up. Well, thanks for spending an evening with us. I'm learning a lot. Thanks, Kathleen. From Dr. Banerji and Dr. Yang and really see how holistic they are when they think about their patients, very pro quality of life, considering that in their treatments as well as mental health, which is really what I'm here to talk to you all about today. And so really taking care of yourself. When I had a little bit of a debrief with Dr. Yang and what she hears from her patients, a lot of the questions revolve around, what can I do? Like, what can I do while I'm waiting, while I'm being monitored, or while I'm on treatment or post-treatment? So these are really important things for folks to think about. And I really want to hit home that it's not only the person that's diagnosed with CLL, but also, I love it, they mentioned their caregivers as well and family members. So this is for all of you, really, to hear about how to aid towards overall wellness. And so I hope that there are some takeaway things that you can walk away with tonight, but really hearing about some of the common mental and emotional challenges that both patients and their loved ones come across after a CLL or a cancer diagnosis, as well as handy dandy tips to cope with some of these challenges, as well as strategies to increase overall wellness. And these are all things really that we should be practicing. And so the doctors did already hit on some of these components here, but really what me and my small in number but mighty team aim to do, there's about 12 of us total in Winnipeg and 10 across the whole rural province. But we really like to consider the whole person. And one of my team is actually here. So Meg Pfeiffer-Brandt takes the, hi, thanks for waving. She takes the lion's share of the referrals for CLL. And leukemia and blood cancers. So really wanted Meg to be here today as well, so you could put a face to a name. And we get the majority of our referrals from the oncologist and the nurses. So people can self-refer as well. They look us up on the website, but really the oncologist and the nurses are fantastic when their spidey sense says to, hey, maybe talking it out with somebody might be helpful. So as you can imagine, I probably not very much because I don't have to tell you that the impact of a cancer diagnosis, it isn't just physical, right? There's an emotional component. It affects us mentally, spiritually for some. And when I see occupational, that may not just mean career, but volunteer work, ministry for some, where people find meaning and purpose in their life, all of a sudden, those things get impacted or affected. Financial implications, right? Especially if you have to travel to a cancer center from outside of Winnipeg. These are all things that we hear about as counselors and really want to be able to name it for you today. Around our part of the building, we often say name it to tame it, because sometimes people can feel like, what's wrong with me? Why can't I settle down? Or get over it. Why am I waking up in the middle of the night? Why are these intrusive thoughts popping up for me? I'm really worried about my spouse or my partner or my adult daughter, but I don't want to tell her about some of these things or tell my loved ones because I want to protect them too. So who do I talk to? And so sometimes talking to one of us, there's no protecting us, there's no editing what you have to say. So that is one service or resource that is part of your um, um, access at Cancer Care Manitoba. And fun fact, I think that we are the only clinical team that sees and opens up charts for loved ones. So we may never see the person who's diagnosed with CLL or cancer, but we'll see their partner or we'll see their adult child, because research also supports that anxiety, depression, anger, frustration, irritability, feelings of grief and loss also impact loved ones. So we want to be able to name that for you today. Anxiety is a word, you know, that's out there, and it may not necessarily mean a clinical diagnosis of generalized anxiety that needs medication. It could range from distress. It could mean worry thoughts that again pop up. And so for some, anxiety pops up in the form of thinking or intrusive thinking or rapid thinking or worry thoughts. For others, it manifests physically. So sometimes you might go to your doctor or your nurse and go, you know, I'm getting this upset tummy a lot of the time, or these headaches that pop up and I can't get a handle on it. Sometimes, not all the time, sometimes it may be a result of anxiety that's not going recognized or going unresolved. So anxiety is a common emotion or experience that people feel, again, not just the person diagnosed. They might be feeling fine emotionally, but your spouse or your loved one may be feeling this way. Depression is also something that we can see, and that can mean low motivation sometimes, avoiding things that used to bring us joy, withdrawal sometimes. It's very, very common, folks, to have a pajama day once in a while, but when we see 10 pajama days, you know, in a row, we want to be able to address what's happening. Sometimes we see, right, Meg, like irritability, mood fluctuations. And so some of us are also trained in couple therapy because regular communication between partners may shift after a cancer diagnosis, a CLL diagnosis, and feeling sick often results in irritability and again, mood. And what we do in our counseling world is to really help folks to reframe that the problem is not the other person or your partner, but the problem is the illness, and really trying to get a handle on coping and maybe adjusting our communication styles a little bit. So adjusting to a new normal, that's something we hear about a lot because oftentimes there is no going back to the times before the CLL diagnosis, right? All of a sudden, worldview or our lens or our ability to cope, our views on life, perspective absolutely shifts. So to give yourself some grace, everybody, and patience and self-compassion with yourselves is something that we really notice in folks and really try to encourage, because it really is adjusting to a new normal for some folks. And so I talked a little bit about this a minute ago, but some common thoughts that we might hear, right, Meg, are, gosh, I wonder if anybody missed anything in the testing, or, you know, feelings might be fear and overwhelm. I said irritability, some heart racing, shortness of breath, sleep disturbance. A lot of what we assess for when we meet folks for the first time is how is your eating, sleeping, and exercise. Those are the big three that are pretty foundational. But sometimes, again, when we're not feeling well or when we're out of our normal routine, that needs some encouragement and some planning, sometimes with a trusted loved one and sometimes with a professional like myself or Meg. And sorry, that little box being covered there, it talks about avoidance or hypervigilance. So remember, I talked about it can be common for folks to avoid things that they need to do that are good for themselves, even doctor's appointments. Sometimes we see that. But the opposite of that can be hypervigilance. So just keep an eye on whether we're, noticing headaches and then our mind pops to, oh, I wonder what's going on now with my health. Or there's that backache. What's that about? Maybe it's the CLL or the cancer. Those are just very common thoughts, folks, that we validate when we see clients, but knowing that that can be normal. So sometimes when we have that backache, we don't now go to, well, I was gardening all day yesterday. That's probably where that's coming from. So that can, and I'll talk about it in a minute or so, be that fear of progression. Fear of cancer recurrence or fear of progression is a lot of what we see as well in our counseling sessions. Again, we do want to normalize it and name that is very common, but also want you to know that there are a lot of things that you can do to lessen the impact of that fear and overwhelm and to really live very meaningful lives. And so again, the depression is very common, and I touched on all of these parts. But under actions, I wanted to point out that withdrawal or detachment from loved ones, that sometimes working with one of us to create goals, even SMART goals, and having that accountability with a counselor to really get back to ourselves and what gives us meaning and purpose is just so important. Somebody that I've been working with for a long time, he was diagnosed maybe 5 years ago. He says one of the biggest things that is helpful for him is to always keep something on the calendar, always have something to look forward to, always have a reason to get out the door in the morning or the afternoon, even if it's for a short walk. And so those connections with other people, that meeting, that routine is very, very important. And for some folks, we hear themes about not necessarily religion or faith, but big existential questions and spiritual distress for some, like, why did this happen? What's the meaning of suffering, or why is this going on? So if this is you, again, I mean, we hear it so often that it's a theme that we really want to name today, because we don't want you walking out if you're thinking there's something wrong with me. It's really just humans trying to adjust to something that is a perceived threat in your environment, is a serious diagnosis and an alteration to your routine. So again, just knowing that, but also knowing that there is a ton of things that you can do. So again, I talked about feelings of change and loss. Sometimes it is a feeling of grieving life before this all happened, before this diagnosis happened. Sometimes when we talk to our clients, it's, at this point in life, I really should be traveling. I really should be doing my volunteer work. Like this is really taking me away from all those things. And of course, accompanying that can be feelings of anger and frustration. And really, we use the word pivot a lot in our sessions, still trying to have those elements of you and what brings meaning to you, but just pivoting a little bit. Maybe it's an adjustment to that idea of volunteering 3 times a week. Maybe it's once a month. Or maybe it's I can't attend all of the family gatherings because of these reasons, but maybe I can have a small coffee date with 1 or 2 relatives. So it can be manageable, but of course, please know that it takes some talking out and adjusting when these things happen. I talked about fear of progression, everybody, and here's the fancy definition: fear, worry, or concern relating to the possibility that cancer will come back or progress. And I think that in our world, we often see this as something that people really want to get a handle on, as well as things like fatigue. I think that's probably one of the #1 most reported things that we hear about is fatigue, and how to manage and live life meaningfully when there are these emotional impacts that we see. So again, wanting to hit home that it does not everything that I'm talking about only impact the person diagnosed, but also their loved ones, and a ton of research that supports that. So much so that one of the support groups that we offer, and Meg, you were running that one recently, is a caregiver support group. There is that as an example, but in our department, we also run things like an expressive arts group, a mindfulness group, or if people are curious, and all kinds of different support groups. So just know that there's a whole team with different ways to support you and your loved ones. So strategies to move forward and optimize wellness now. Again, showing our handy dandy infographic there. Maybe there's something that is popping out at you as you look at it as an arena that you want to work on. Maybe there is something that you have been meaning to get back to, but really want to prioritize that. So just noticing as you look at this, what pops out at you as being a part of yourself or a part of your life that you would want to work on. This is another, when I was debriefing with Dr. Yang before tonight, a big question that people come across is, or wonder, what do I tell my family and friends about this diagnosis? And I wish I had one big perfect answer for this, but really we see that it depends on your own personality, your own style. Sometimes we see that people are very private and want to keep it so. And so what we suggest and see works for a lot of people is kind of having a go-to line when people ask about your health. Sometimes it's, you know what, I have my good days and my bad days, and sort of keeping it at that. Sometimes it's, you know, there's a lot going on, but right now I really want to focus on, hearing about your life. You know, a lot of people don't want to be the focus necessarily when it comes to social events. You want to know what everybody's doing, but being able to name that for the person sitting across from you can be really helpful for them. Sometimes we see people really like talking about their story and their journey and even post on social media. So if that's you, that's normal too. So just reflect on really what sits most comfortable for you and your family, and have a go-to kind of response, I guess, when those social gatherings happen. So the docs already talked about this, the importance of exercise. And on the mental health side of things, I like that quote, exercise is the most underused antidepressant. And really, if you want to get pen to paper and see that, rate your mood before you go for a walk, 1 to 10. How do I feel? Kind of blah. Maybe it's as strong as an 8. But then you go for a little bit of a walk for 20 minutes, you come back, you pull out that piece of paper. Chances are that blah feeling is going to decrease from an 8, maybe down to, who knows, hopefully a 3 or a 4. So when you start to see the evidence of how good you feel after a really simple exercise activity or routine, you tend to want to do it more. Nutrition. Fun fact, that is also a service under Patient and Family Support Services that you can request a referral or call us yourselves to see a dietitian, because these things are so important. I'm definitely not a dietitian, but some of the very big common things we hear the dietitians talk about are the importance of fruits, vegetables, protein, healthy fats, not a surprise. Also minimizing processed foods and sugar. Sleep, one of the big 3. We always say, how is your sleep? Are you able to get back to sleep after you wake up in the middle of the night? So just ensuring, again, some quick tips here, that your environment is dark and quiet. We like to say in our counseling sessions to treat yourself like a baby as much as possible. So we're really good at having those quiet, soothing, calm environments for babies, for them to go to sleep, reading, maybe a warm bath, soft music, or low lights. But then what do we do as adults? I know I'm guilty. I'm flipping on my phone, or maybe the TV's on. Of course, I'm not going to go to sleep, right? So really taking an evaluation of what your sleeping environment is like. Again, that daily exercise, avoiding big meals in the evening, and avoiding the other big three: caffeine, alcohol, and cigarettes, especially before bed. So getting up at the same time each morning is something that we like to talk about. That's more important than what time you go to sleep, because there's something about the time that you get up in the morning and keeping that consistent. Unfortunately, that counts for Saturdays and Sundays too, when we do want to sleep in a little bit. If we put it to the mind to get up at 7 o'clock every morning, chances are our bedtime also sort of adjusts and we're able to get more sound sleep. So those are some quick things to keep in mind: keeping naps to a minimum, folks, and really only staying in the bed when you're tired. They say that the experts say that if you've been tossing and turning and looking up at the ceiling for 20 minutes, it's time to get up and go to another quiet part of the home until you feel sleepy again, and then going back to bed, because we don't want the brain to associate the bed with, again, TV, working, being on the phone, because that can keep us up. So if you're interested, mindfulness meditation is getting a lot of hype lately. Lots of evidence in the research and lots that's out there for you to look into. But really, it's a way to observe what's happening for yourself without judgment. Very helpful for stress reduction. It can be done anywhere at any time, even in a busy weight room. A lot of the clients we work with sometimes engage in these meditation mindfulness practices while they're nervous waiting for a weight room, for their doctor's appointment. And so there's a lot of apps out there. You can even log onto YouTube and search for mindfulness meditation, and you'll get a lot of options coming up, some really pretty and visual with forest scenes and waterfall sounds, really helpful for bedtime as well. I talked about self-compassion a little bit, and I won't go into it too much because that's a whole evening in and of itself. But that website there focuses on the work of Dr. Kristen Neff, who is a psychologist in the States. And really, there's something about the inner critic that we all carry around with us sometimes, even when things are rough, and really quieting that inner critic that can go a long way towards mental health and wellness. And so processing the experience of cancer, sometimes people like to journal. Try that out if you'd like. Sometimes people like to talk it out or join a support group. A lot of ways to process your experience so that it doesn't stay here and that you don't carry it around. Lots of evidence about mind-body strategies, music, art therapy, just getting creative and moving the body. Lots out there, folks. And sometimes, if people want to take a picture of that, we get more motivated to act on wellness when we create SMART goals. So not that it's, one day I'm going to go for that walk and get started on that. No, a SMART goal means this Friday at 6 o'clock, I am going to go for a walk with my buddy Meg, and we are going to walk 2 kilometers. And so when you start to define what you really want for yourselves in life and really put pen to paper, again, it's more likely that those things will happen for yourself. And I really like this quote. It was at the back of a book, right? Normal. What is that? It's really just a setting on our washing machine, folks. So individual, so different. Wherever you are on your cancer journey, it's going to change. But really to be giving yourself grace and compassion, because there's a lot coming at you all. So just wanted to validate that. And here is our phone number, everybody, if you are interested in any of the services that we talked about: counseling, group programs, our dietitian, as well as where Kathleen and Ali live most of the time, our wonderful resource and information center. You can just call there or go on the Cancer Care website where our monthly newsletter is always available. It's just a click away and it'll list everything that is available to you and your family. So thank you.
I'm going to invite Dr. Banerji and Esther Ajua back to the stage, and they're going to be talking a little bit about information about our tumor bank and research. I'm going to introduce Esther because we haven't met her yet. She is a clinical research assistant at Cancer Care. She completed her Bachelor of Science degree at the University of Winnipeg. Prior to joining the Manitoba Tumor Bank here at Cancer Care, she's been deeply involved in research across several research institutes in Manitoba. She has a strong interest in health and cancer research. Welcome.
Thank you, Kathleen. Good evening, everybody. Some of you have seen me in the clinic just after your doctor, and I always come in to say hi. So today, I will just briefly talk about the tumor bank, the Manitoba Tumor Bank, and what we usually do, and its connection with research. Okay. 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 So what is a biobank? If you look at this slide, what comes to your mind when we talk about the bank is where you usually would spend your money and do stuff, right? But when we talk about the biobank, is something completely different from what we know. For the biobank, we're talking about collection of fluids or body fluids such as blood, urine samples, tissue samples, and relevant medical information. So the bank is an integral part of the Research Institute and it's on the 6th floor. And currently the Research Institute is being headed by Dr. Sarah Dentry and Dr. Sachin Katyal. So the bank plays an important role in the research. So what's our vision? Our vision is very simple and it's over there, just fostering research benefiting Manitobans and Canadians. So just see the tumor bank as the window between the researcher and the patient. So I meet you over at the clinic and I ask you if you would like to participate in our research. You say yes, and then we can collect blood from you and also clinical data from you and give it over to our researchers. So that's basically what we do. And this is very important because of the patient, clinician, and researcher partnership that is being formed. And MTB has impacted a lot of our research today, our research projects, and we can see that a lot of peer-reviewed publications have been made. And most importantly, in terms of funding, the MTB has helped a lot of grant application that has ensured the continuity of research. So which is really important today. And one of the questions I always get whenever I meet patients is really simple, and they would usually just ask me, is this new? How many patients are here? Am I the first person that's being consented? And when we look through it, MTB is not new at all. It's been here since 1993, and it initially started as the Manitoba Breast Cancer Tumor Bank at the University of Manitoba in 1993. And then it formally became the Manitoba Tumor Bank in 2003. And the CLL bank was established in 2004, and then we began to expand, and you can see the head and neck cancers in 2006, and then the prostate cancer in 2010, and then the ovarian cancer in 2012. So we've expanded to several disease sites. It's not just CLL that we do this for. We have so many other areas that we are currently working with. And during COVID, there was a big hit to the bank and collections kind of stopped. But in spring 2022, we're able to get back in shape. And there was a change of leadership in 2022. Dr. Sachin Katyal became the director. And right now we are back to normal, and we are collecting samples, we are processing samples, we are storing samples, and we are collecting clinical information. So as I've said, I've given a brief overview of this already. When you come in here to see your doctor, you either meet with Dr. Banerji or Dr. Ying, and that's your first point of contact when you come in here. And then I come in somewhere to meet you after you talk to your doctor, and they kind of ask you if you would like to speak to research. So I come with the informed consent to let you know what the bank is all about. And if you consent, we can collect blood, tissue samples, and also data from you. So this all comes together. So when you donate your sample to the bank, we can process, we can store, we can catalog your sample. And then if you also consent to the bank, we can also take your clinical information and create our clinical database. So how does all of this come together? When we give it to the researchers, so they can request samples, they can request clinical information for research. So the CLL patient contribution to the MTB drive the CLL research in Manitoba. You guys are doing an amazing work whenever you consent and say yes to research. And right now we have over 1,900 consented individuals at the MTB bank. And for the collections, we have more than 8,000 collections, like you can see, and that includes the blood collections and the bone marrow collections and other tissue samples that are being collected by the bank. And after processing the aliquot, we have over 100,000 was collections, and that's very significant, and that's very good. And that's because you guys have made it possible for the bank to have this much, and we are very grateful for it. So far, the bank has released about more than 11,000 samples, and we have about 41 individual projects from 2009 to 2025, with 2 international projects and 9 national projects. So one of the interesting things about the bank is the normal healthy donor that we have about 300 consented individuals. So we have patients, their family and their friends, they donate their cells, their blood, just as a way of supporting their spouse. And that's very crucial for research because we have something to compare the CLL samples with. And this is also good because the MTB staffs and the staffs here at CCMB, a lot of them are in the bank. They've contributed, they've given out their blood, and that's really good. That shows how much they believe in the research that we are doing over here. Again, as I've said, it's all about partnership. The CLL research begins with you, the patient engagement, your contributions, your input, your time, and we need everyone to help us out. So by helping us, you are also helping the researchers, and not just the researchers, you are helping the future generation of people who will be diagnosed in the future. And that's something really good because then we can see that we will be able to understand the disease better. There will be better drugs, better research that is being done. So one of the key things we are actually working on is the TFRI project. And it's not just about storing samples. I know some of you are really wondering what is being done or what has been done with these samples. And that's what one of the stops over here, which is the TFRI project. So for the TFRI project, the focus is on precision oncology. So we are trying to use the individual's genetic information to tailor a specific treatment for that particular individual. And this project is really good because it's not just here at the Cancer Care Manitoba Research Institute. We are working with other research institutes across Canada. And the goal initially was to sequence tumors from 15,000 Canadians with cancer. But right now, that goal has been improved to 30,000 Canadians. So we are on the 5th year, and Dr. Banerji is involved in that project, as long as her husband, Dr. Shatri Banerji, and Dr. Sachin Katyal. So they have been there, and we are currently on, I think we are on the 5th year of the project. So because the phase 1 started in 2020, and this is 2025, so this is the 5th year of the project. And we have a lot of our data managers who have been working on that project. And it's not just CLL, we have the lung cancer and the mixed cohort, and they've been doing an amazing job for the last 5 years. So for the phase 2, which is starting in 2026, and is going to last for another 5 years, the goal is going to change. And the goal is to sequence every Manitoba cancer patient who walks in through the door. So that's the goal and what we are trying to do. So what do we need? We need the patients, of course, to donate blood samples to the bank. And then we need healthy donors who will be matched with those samples, and then the clinical data element. So what are we sequencing? We are sequencing the tumor, and then for the whole genome sequencing and the RNA sequencing. And also, we are also doing the for the normal control patients, we are doing the whole genome sequencing. So this is our team. This is the Manitoba Tumor Bank and Dr. Sachin Katial's lab together. And they've been doing an amazing job since we've been together. There have been a lot of changes, but the team has been amazing in the job that they've been doing. And I just want to say a very big thank you to our patients who have contributed so far. And for those who are still unsure if they want to join, we encourage you to, but it's still your choice. But being a part of research, you have made a lot of things easier. You have made research really beautiful and easy for the Research Institute and for the researchers. And we are indeed very grateful. So thank you very much. So I'll hand over to Dr. Banerji, and she will talk more about what we've done with your blood samples. Thank you.
I am cognizant of time, and I know we are running over. I'll do my best to summarize so that we can get to actually the most exciting part of the evening, which is our patient story. So I wanted to take this opportunity to thank everyone who has come tonight, but also we couldn't do what we do without all of you, whether you're a patient, a care provider, a caregiver. This is one of the most multidisciplinary teams within Cancer Care Manitoba. And because of you and your active participation, we have been able to push the boundaries of care when it comes to the integration of, let's see if this works. I want to be quick, so nothing's going to work. Here you go. Really pushing the boundaries of care and research. And I think our team, which was driven by Dr. Johnston and Dr. Israel before, really brought, a level of care that always pushed the boundaries. And that can only happen when you're integrated with research. So many of you have participated actively in research through the donation of your blood through the biobank, as was highlighted by Esther. But that participation can stem in many different ways. One is by the donation of your blood so that we can do fundamental research. We can also do research that spans the bench lab and clinical care. And we now also do something called real world evidence, which is trying to understand how patients are treated and active participation in the clinical trials unit through clinical trials. So the Cancer Care Manitoba does have a mandate to have patient and family advisors to help inform research at Cancer Care. And this can happen at the planning stages, at the design stages, reviewing the results, and basically ensuring that patients have a voice. And I think one of the key things is that we have curated and created an advisory board of some of the patients here and across the country to help us to drive our research direction. And we really want to ensure that we're answering questions that are important to you. So our model of care is actually unique in Canada. Most patients with CLL are actually fragmented across different hematologists and physicians, and they're not in a centralized clinic. So Manitoba actually has the advantage of probably the largest concentration of patients with this condition that are monitored by 2 physicians and the teams that support them. That allows us the ability to follow over 1,500 patients and understand their medical needs and draw conclusions around their indications to treat, the treatments and their impact, and also accrue to clinical trials. So what I have here is how you as the patient touch our community. So the CLL clinic is where the patient is centered. We have access to those samples to the tumor bank, and we have patients who can enter into clinical trials. From that, we curate data around, in a de-identified way, the journey that each of those patients has. And we can also then ask questions and collaborate with other investigators within the university community. Now, whether that's here or across the country, it depends on the question being asked. And with that is linked not just the information that we learn at Cancer Care, but we can also understand how your condition interacts with the rest of the healthcare system and link the information to how many emergency room visits, how many doctor's appointments did you have, and was that caused by the new medication I gave you, or is that independent, so that we can truly understand the impact of our treatments. And I think one of the things that we're starting to see, and Esther touched upon, is that we're at a point where there's definitely this push for personalized medicine, and the amount of information we need to understand that is being driven by a lot of new technology and a lot of big data. So we're able to participate in these national endeavors because of this, because of the thirst to understand your specific condition and leverage the technology we need to do that. So we have those advisors. We also want to make sure that care and research are accessible to all patients. So we have lots of different champions helping us to do that, both within the cancer care community as well as the CLL community. I wanted to define some of the research entities. One is what we call fundamental research or preclinical, but these are basically using models to try and discover new things about CLL, whether that's to study the biology of the cancer cell, to discover new and safe treatments, or to overcome drug resistance. But we can also use these model systems to understand the immune system and the environment of the cells. And Dr. Ketial and Dr. Johnson are leading multiple studies on these projects to try and improve the current treatments that are available, to find ways to skirt drug resistance, and also potentially discover a biomarker to try and improve treatments that exist. So your work is touching lives, maybe not for you at this moment, but definitely for the future people. We're also trying to understand new treatments that I didn't touch upon today because of the limited time, but we're trying to improve CAR T therapy as well. We're trying to understand the role of the different cellular compartments and the impact our treatments have on them. And we're trying to understand how we can discover new drugs by understanding different genetic and genomic approaches, as well as how the immune system works. So these are just a smattering of some of the projects that are ongoing. We have one open clinical trial right now for new patients who are within the first 18 months of their CLL diagnosis and are defined as high risk, to understand whether or not, if we treat them early or delayed, if they benefit. Because we've learned that treating everybody doesn't help us, but maybe targeting the patient population that is early, that is high risk, and intervening early with them may be a benefit. But we also run clinical trials for industry to access new treatments for our patients, to change the standard of care. This is why I haven't prescribed chemotherapy in 5 years, but also so that we can learn with our patients at the same time how to implement and use these new treatments. Real world evidence is really learning about patients in the real setting. clinical trials have entry criteria, they have rules, they have regulations, and we can only give certain people those treatments. But real world evidence is actually, how does a specific drug affect the people we treat in our clinical practice? And what can we learn from that? Does that drug have side effects that we didn't know about? Does that drug have efficacy in patients we didn't previously use it in? But it really gives us a sense on how these drugs work. And then we can use this information to actually collaborate both nationally and internationally. But more importantly, it helps us advocate for new drugs in Canada. So we can use that evidence to say, these drugs work. This is how we've done with their kind of access programs. So we think this drug should be funded by the national funding bodies. So these are some of the publications and manuscripts which we use as kind of output measures of how well we do. We also have had what we call prospective investigator-initiated studies, but the main reason the main reason to show this is these are studies where we may not be giving you a drug, but we're interested in learning about how patients within our clinical population may be impacted by their CLL. So we know that CLL is often a disease of older adults, and older adults can be defined as frail. So we've actually done a study where we've accrued over 72 patients and 30 healthy volunteers without cancer, and we're just studying what is their immune system doing, what is their frailty assessment. So they do a fit test, a walk test, and we're trying to understand who is what we consider fit and who we consider frail, and trying to understand their outcomes. Do they progress earlier? Do they get other cancers? Do they do better in their treatment? And trying to understand how all these different things that make us as a whole impact our entire being, so that we can better understand you as a person and the treatments we give you. So the last project that we have that is going to be started and will be recruiting soon, which I've titled The Truth About Gut Feelings, which I think will speak to Cheryl and Meg's roles, is I'm often asked questions, and we're often asked in the clinic, what should I eat? I don't like the active observation piece. How is this impacting our mental health? So we're actually trying to understand this. So we're in the process of getting ethical approval to really survey our patients within the first 2 years of their diagnosis, or if they're going to be embarking on treatment, to understand their mental health, their nutrition, and the impact on their cells, and then obviously on the person itself, to better inform and provide the resources for care. And I'm going to not go into details around this, but we also have a CLL website that is going to be launched in the near future with information about patient care, about the clinic, and about the research opportunities and the researchers. So you'll have ample opportunity to get that information. All right, so with that, I would like to pass it over to Kathleen.
Thank you, Dr. Banerji. We've reached the highlight of our evening when we have our very special guest, Estelle, that has agreed to come and share her personal story with us. So I invite her up to stage now. Thank you.
Is this one off? So that this one's off, eh?
That one, yeah.
Okay. I'm Estelle. I'm 89 years of age, and this is my story. I grew up in Ottawa and went to the University of Toronto, where I met my husband, Richard. We moved to Winnipeg in 1958, where I graduated from the University of Winnipeg. I have 4 children and 6 grandchildren. My husband sadly passed away in 2003. My first job in 1959 was as acting registrar at the University of Winnipeg before starting a family. The rest of my career was in public relations. First as Director of Public Relations for the Health Sciences Centre in Winnipeg, then in the same position at St. Paul's Hospital in Vancouver, and the Department of Community Services for the province of Manitoba in Winnipeg. I retired in early 2000, but continued to lead an active life. Then the unexpected happened. My family doctor sent a blood sample with a continuing high white blood cell count to cancer care. I was diagnosed by Dr. Banerji with chronic lymphocytic leukemia, CLL, in 2018. When you feel healthy, it's a shock to get a cancer diagnosis. It happens to other people, and now it was happening to me. I was under observation. In 2019, I had a test called FISH. I had 2 genetic factors which make me high risk. Because of these factors, chemotherapy was not advised. In 2020, I became eligible and had the opportunity to be part of the AstraZeneca 312 clinical trial. I came to Cancer Care Monthly for blood work and to see my nurse and Dr. Banerji. I also agreed during the trial to have extra blood samples taken for research, which to me is vital in having others benefit from my experience. On the trial, I had a daily dose of the drug acalabrutinib. While the drug has many side effects, I was fortunate not to have any except tiredness. I had a bone marrow biopsy during the trial. 4 years later, after a CT scan, the disease, however, had progressed and the drug was not effective anymore. I stopped the trial last May. I was eligible and able to take part in a new randomized clinical trial called LOXO 222. I started the trial last June. It has 2 arms, one involving 3 drugs and the one I'm on, which has 2 drugs, venetoclax and rituximab. I was treated with rituximab once a month for 6 months by infusion, as required by the trial. This took several hours each time at Cancer Care. Since the start of the trial, I take venetoclax every morning in 4 pills and try to drink a lot of water as required during the day. My blood work on the trial so far has been stable. I've had several CT scans as part of the trial. I've recently progressed from coming in every month to Cancer Care to once every 3 months. I'm about halfway through the 2-year trial, and then there will be follow-up. Fortunately, the main symptoms I have had to deal with is more fatigue. I handle this with a short rest during the day when I need it. Also, the drug is sometimes hard on my stomach, which I manage to tolerate. Otherwise, I've fortunately had no side effects. Because the body's immune system is suppressed with CLL, I've made sure to keep up with all the recommended vaccines. During COVID-19, I was more vulnerable and wore a mask in group situations. I did get COVID twice. I had to take an antiviral drug in both cases, but I had a good outcome. I've had time to reflect since I was first diagnosed on what has helped me face the challenge of CLL and to get where I am today. If I had been told I had a chronic disease as a young person, it would have been depressing. Being told I have a chronic disease in my 80s gives me hope. Because it's not acute, I feel I have a better chance of living longer. While CLL has been a focus for me in the last 6 years, I feel it's important to stay active and engaged. I still live independently. I'm close to my children and grandchildren who live in Winnipeg, Vancouver, Toronto, and Vermont. I travel a bit. I do aquasize, golf, and play bridge. I read, follow the news, go to concerts, and belong to a study group. I spend a lot of time with friends. All of these give me something to live for. One major event has shaped my life, my career, a larger view of the world, how to deal with problems, the loss of loved ones, and the challenge of CLL. When I was 17, I was selected as one of 50 girls across Canada to go to the Queen's coronation and a 7-week goodwill tour to the British Isles and France. The trip was sponsored by the late Garfield Weston, who was an industrialist with close ties to Britain. It was a life-changing experience. On that trip, Garfield Weston gave each of us a medal with the image of a sailing ship on one side and on the other an inscription which reads, "'Tis the set of the sails and not the gales that determines the way they go." That motto has guided me throughout my life. 50 years after the coronation in 1953, when the Queen was celebrating 50 years on the throne, several of the Weston girls sought to find each other. They succeeded. We had our first reunion in Ottawa in 2003 with 38 women. In the following years, we had over 10 reunions across Canada and have forged lasting friendships. We've sadly lost a number of the women. Many live in assisted living. 17 of us still keep in touch with visits and a Zoom call every 3 months. The culmination, however, was the opportunity in December 2023, 70 years after the coronation, for 13 of us, including me, to return to London. In 5 days, we retraced some of our steps and had a surprise audience with King Charles. That was truly exciting. A documentary called The Coronation Girls was in the works, and the camera crew was with us in London. It premiered in Toronto this past December. I was able to share this wonderful event with most of my family. The documentary has been shown since then across the US by PBS and in some Canadians, but not in Winnipeg yet. It's available for streaming on PBS. This whole experience as a young woman until the present day has had a major impact on me. The motto I read earlier has stuck with me. A remarkable thing happened just this week. King Charles delivered the speech from the throne. Prior to that, this past weekend, CBC and CTV interviewed coronation girls who were in Ottawa. They had the opportunity to see King Charles and Queen Camilla. Our life-affirming story was highlighted on the national news. It made me realize, with what is going on in the world today, how fortunate I am to be in Canada and to have access to the world-class services we have in cancer care in Winnipeg, to have leading-edge researchers and physicians like Dr. Banerji and Dr. Yang navigate my treatment for CLL, to have nurses who are patient, answer my questions, and make me feel comfortable when I have a test, to have lab technicians take so many blood samples with such care, to have cancer drugs available at no cost in Manitoba so that it doesn't become a financial burden, to have cutting-edge research that is helping me to live longer, to have volunteers bring me a cup of coffee with a smile to help me pass the time on visits to cancer care. I don't know how many more tomorrows I have in my life, but I know that I'm here today to share my story because of cancer care, and I'm forever grateful to them. Thank you.
Wow. That was really that was amazing. There's still time, I think, for you to pursue a career as a inspirational speaker. That was a lovely thing. Should go for it. I'd like to ask the speakers to come to the stage now. We're going to have a brief Q&A. I know we've just run a little bit out of time, but as we're doing the Q&A, I'd also like you to take a moment to complete the evaluation. I'm going to have our volunteers just pass that out to you right now. So maybe our speakers can come up front. And if there are any questions at all, you can take the time to ask them now. There's a four. I'll give you that.
So we're just gonna, while you're filling out your evaluations, go through some of the questions online, and then we're happy to take questions from the audience. So one of the questions was about traveling once diagnosed. So often in the monitoring stages, we have no issues around patients traveling. The complications often come when you're either close to being treated or on therapy and just the provision of healthcare. But there are some important things for you to understand if you are traveling. If you have insurance or seeking insurance, it can affect your insurability. And so it's important to disclose in case you do have a complication or need health care in the place that you're traveling to, because otherwise it could be denied if they find out after the fact. So really important to know that. Within Canada, we do have like national coverage. So if you do get sick visiting your grandchildren or your family elsewhere, it's less of an issue, but mostly travel across borders is where this becomes an issue. while you're on treatment, it's really where you are in that journey. If you're really early in the treatment and we haven't established that you aren't going to get any side effects and the blood counts can go up and down and you're more susceptible to infections, this can lead to challenges because you might need the healthcare system. And if you're in a place that doesn't know your story, or you have to pay for that care, then that could lead to some challenges as well.
The only thing that I kind of would add to that, completely agree. That, I'm very cognizant of quality of life. So this is a very important trip. We'll have a conversation together how to get you there the safest possible way. We can never guarantee it, of course, unfortunately, but we'll talk around it, so be open and don't be afraid to ask those questions because you never know what that conversation is going to lead to. Second question was, can CLL patients donate blood? So assuming you're talking about donating blood to Canadian Blood Services. And the short answer is no. Canadian Blood Services are very, very strict for a lot of good reasons as to the donors. And because you do have a blood cancer, you cannot donate to Canadian Blood Services.
But you can donate to the tumor bank.
Yes. That's a different donation and we welcome those. Do you want to then just switch back and forth?
Oh, that's great. So I can do this one. So the third question was, how can patients participate in the TFRI Gold cohort? So we are allocated a certain number of patient samples for that. So
What it stands for? You talked a little bit about it, right? It's a national.
Yeah, so it's really looking at a national strategy. So we have a lot of information banked in databases around genomic material, but it often comes from patients in the United States or internationally across the world. And actually the information on Canadian patients specifically is lacking. So this is the federal government's way to try and encourage a repository of Canadian data for Canadian patients, so that researchers can actually leverage the Canadian information opposed to what the fabric of other countries look like. So there's certain slots for every cancer group, and sometimes we have to ask a question around a research strategy. And so the samples are actually selected based on answering that question. And so they can come from the biobank. There may be some cohorts that are recruiting actively for other cancers, but right now it's more of a, what do we have in our bank that will answer a question that can be used for that purpose? So I'm not sure that there is a volunteer sign up. There are other opportunities like the study that I presented, or other researchers that are looking for samples. And often on the consent form, there's a, if there's a new study, can we contact you? So tick that box off so that we can make sure that we engage everyone.
Estelle, I have the pleasure of reading this out. And it says, that was amazing in caps to your presentation. We thank you so much. It was so heartfelt. Yeah. Yeah.
All right. So I think that gives us the opportunity to take some questions from the audience.
So the question from the audience is anyone screening for MBL? So as far as I know, we don't have an active program going out there telling docs to do blood counts. It just naturally happens when people go do blood counts with their family or whoever, their physician, and it just happens to get picked out. We do know some numbers behind MBL, and this is dating back decades ago. This is how MBL got started. It's actually from blood donors. U.S. Center blood donors, 10,000 plus blood donors, and went back and screened them all, and they can figure out exactly how common MBL it is, and it is very common. So there's no program to go and actively seek them out, but we've had a lot of like studies to know quite a bit about MBL.
So I'm just going to supplement that by saying there's when it comes to cancers where intervention is required, screening programs have been established. Breast cancer, prostate cancer, and lung cancer for smokers with high risk, and colon cancer and cervical cancer. So those are the main areas because these are life-threatening cancers where time from diagnosis to intervention is impactful. So that's a very good use of resources to prevent other long-term complications of those conditions. MBL is a little bit different. Not everyone with an MBL clone develops into CLL. Some of them just fizzle out and go into nothing. But the other problem is, yes, it's not a cancer diagnosis, but it's a pre-cancer diagnosis. And there might be some other implications to life insurance, other insurance policies that may then preclude you if we screened every single person and found people that had CLL that was asymptomatic, because we would just be screening for MBL at that point. We would capture people with undiagnosed CLL as well. So it's not a good recommendation for a disease in which we are not really doing anything right away either, because they're asymptomatic and the management is monitoring for that initial stage.
That's a great question. It's a kind of I kind of summarized the question in I kind of heard it in two ways, and correct me if I'm wrong. One is the genes behind the cancer. Is this cancer a genetically driven process? And then the other question is there like a family inheritance of this? One is easier to answer than the other, and one is Dr. Banerji is better at answering than the other. You know, if you go deep down in cancer cells, you're going to find abnormal genes. And that's kind of the direction that cancer research is going in a nutshell. We are trying to find those really key genetic mutations and find commonality of what happens in CLL cells, what happens in lung cancer, finding that key genetic problem so that we can find a way to fix it and turn the cancer cells off. So that's a bit of the story behind what we call personalized medicine or precision medicine, and the rationale behind a lot of these global trials to understand the genetics. Can we tease out a genetic profile for this cancer that we think is so important that we're going to target, or how it's going to change treatment and outcome? And that's why CLL will have a different genetic pattern than Waldenstrom's. Waldenstrom's very classically caused by this gene called MYD88. That's what we know. That's what we're going to target. But it's going to be different than another type of cancer, another different. So we're trying to personalize medicine, personalize these cancers. But deep down, yeah, there's genetic mutations that probably somewhere along the line, you know, created this cancer cell. The second question is about genetic inheritance. And yes, we're starting to see a signal that about roughly, give or take 10% of patients with CLL will see a family inheritance. And one of the projects we did not talk about that has been in the works for many years now, because you have to study many generations of people, right? Is finding family, identifying those families that have a clear genetic inheritance of CLL. This is not the gene. This is actually inheriting CLL from generation to generation and studying those folks. So we actually have a study going on right now at Cancer Care, learning about that and what makes them different and why is there a genetic pattern there and not elsewhere. So about 10%, I generally say. I want to see if Dr. Banerji has something to add.
Yeah, so what we believe, if we take all the patients who have family members that have had CLL or blood cancer, it's not like mom and dad, one of them has CLL, that one of the kids will have CLL. It seems to skip generations, and there might be something within the genetic code that might make one of those family members more susceptible to cancer. But interestingly, it's not just CLL. We often find that there's susceptibility to other blood cancers, so multiple myeloma, Waldenstrom's, like you said. And, you know, it's unclear about the immunodeficiency one. That one I can't comment on. But there's papers published through the Mayo Clinic, who is leading a lot of these endeavors, to definitely state that there's some sort of susceptibility factor, but it's not the same in every family. And what you become susceptible to is also, it's not always CLL. So blood cancers can travel in families. So we often ask at your new patient visit, any family history of cancer, and then we'll ask the question again, any specific blood cancer history, because we're wanting to identify any patients and family members that might be affected because of this curiosity. And as we're doing more cataloging of patients and their families and their genomes, we might come to an answer over time. So the causes of, so even the genetic theory is very bland in CLL. Like, unlike smoking that creates a whole bunch of damage to DNA and leads to bad tissue cells and tissues like lung and bladder and things like that, there hasn't been clear risk factors identified that cause the CLL cell to develop. I think we still don't understand why that happens. But we still want, because that second cancer risk is so high, we, in addition, want people to follow the guidelines. We want them to protect themselves from things that are risk factors for other cancers like smoking, alcohol, and ensure that people are active.
Got a question about that tumor bank. Does Cancer Care ask the patient to donate, or does a patient have to come up to Cancer Care and ask to donate?
So usually during your visits to see Dr. Banerji or Dr. Yang, we usually try to approach you for your very first visit. So for the very first visit, then I would usually come in to ask you if you would like to be a part of the program. So, but sometimes we tend to miss for several reasons, maybe clinic flow or maybe so many reasons happen why we may not be able to approach you for your very first visit. But in that situation, you can easily ask your nurse or even your doctor and let them know that you would like to participate, and we would, start you up all along with the research process. So I would say both ways. It works both ways. If you would like to participate and we haven't approached you, you can easily ask your doctor, but that's how it goes. Thank you. Yeah, if you would like to donate, that's really good. For example, if you have a visit to see Dr. Banerji or Dr. Yang, you can again ask the nurse, and the nurse will give us a phone call, and I can call. Yes, and I can come meet you guys there, and I can set you up on our normal bank.
I will say, for the healthy family members, although the Tomorrow Project is looking for lots of donors for younger to mid-age, we often are looking for patients, for family members or volunteers that are more in the age range of the patient population.
Yes.
I mean, because we're trying to match the controls, but we do accept a range, and the bank needs samples on its own, but just as a FYI. Yeah.
covariate analysis and discount and keep in order to attempt to maximize it, or we have to split up environmental conditions and say look at the outcomes of environment. So many phenomenal, but I did think that was interesting.
So in terms of clinical data, it depends on what is being asked. And I think Nicole would actually do a better job because she's
and repeating variables. So we don't collect information just once. Every time it changes, we collect it again. It adds to this. And then when research becomes complex, they tell us that they need, and we can give them what they need. So sometimes they want just diagnosis of something. They need information pre and post all of the treatments that certain patients have been on and like that. Over 1,000 variables at multiple. Dedicated just to it.
And the subsequent question I could ask, and that is availability of staff. That's one. I don't hope you will, be able to do a output. I guess.
So unfortunately, right now, the way our ethics are written, the only information we can give out back to a patient is we have found something that usually something in the blood work that should not have been there. So we do with the blood samples, let's say you're a CLL patient and we find a precancerous marker for something else, that is the only kind of information we currently have permission to go back to the patient with. So we have a process in place through, so the University of Manitoba has a research ethics board, and any and all research that is conducted through in Manitoba has to go through them, and they have a whole panel of experts who will look at this over. And so we have a whole process where we go to them and tell them that we found this unexpected result, and then it gets communicated to their doctor because they don't have the link, right? So
A number of your tests and studies
yes, so anything done in yes, they just release it here.
I'm gonna just, I know that it's getting really late, and it's a very specific question. So just gonna ask if there's any broader questions. Otherwise, anyone who wants to feel free to go, they can go. They don't have to be held. But I wanted to thank everybody for coming tonight. I don't know if Kathleen, do you have some
Thank you
closing-
to Kathleen. Kathleen is really involved. Thank you.
Thanks everyone for coming. Please don't forget to drop your evaluations off, and thank you. And thank you. Have a safe trip home, everyone. Okay. Thanks so much for being here.
Sorry, I didn't mean to cut it short. But